the respected doctors present here. I, Dr. Snehal from the USV medical team, welcome you all for today's interesting session, yet another session in the CME India series, where we will be touch basing upon an important topic, that is spirometry in clinical practice interpretation, the must-know pearls. For this fantastic talk, we have stalwarts across the country who have gathered this evening. Firstly, I would like to introduce to you Dr. N.K. Singh, sir, who is he's the founder and also the editor for CME India. Handing over to you, sir, to introduce the dignitaries for the evening.
So, good evening to all our viewers. Today we are going to start the next episode of the CME India webinar with the USV. First, I will introduce Dr. Vijay Patni. I think our viewers are well aware about him, that the current designations are the HOD Diabetes Wellness Clinic at Kolkata. Lots of research papers, awards and achievements. So he will conclude the session at the end. Next, Dr. Akash Singh from the Baroda. He is a senior consultant medicine diabetology and at the Baroda, Gujarat. He also invited faculty at many places, many research papers, achiever and many things. So I think he will also conclude later on with the vote of thanks later on. But now today's moderator of this very important session on spirometry, and why I chose this topic, that lots of physicians are not able to interpret the findings of the spirometry. This is my personal experience. And although even when it is too much indicated, we are not advocating it. We know that it is one of the most readily available and useful test for all pulmonary function, and not only in the respiratory diseases. These days in the diabetology also, many indices of the spirometry are reduced. So all the physicians and even the diabetologists, they should be very much aware about how to read a spirometry. I really great pleasure in introducing Dr. Devi Jyoti Das from the HOD Respiratory Medicine at Sri Balaji Institute of Medical Science, Director at the Nivet Chest and Eye Care, Raipur, MD Pulmonary Medicine, DNB, EDRM, Fellowship in Sleep Medicine, Allergy and Smoking Cessation, publications in more than 20 international as well as national journals, speaker at 3 international conferences and over 20 national conferences, and member of European Respiratory Society, Indian Chest Society, National College of Chest Physicians, Chest Council of India. So welcome, Dr. Devi Jyoti Das. Now I will hand over to you to moderate this session. Please introduce our speaker of today.
Thank you,
Dr.
sir.
Jyoti.
Thank you for the great welcome. And as you have mentioned, today's topic is very important, as especially for the physicians, because spirometry is such a simple but important test, and everybody should know about it. And to make everything clear, we have my great friend, Dr. Atri Gangopadhyay from Ranchi. He is a pulmonologist at Pulse Hospital, and he has his own OPD set up with complete PFT facilities, and he is the pioneer of oscillometry in Jharkhand. He has delivered over 25 lectures, and he has special interest in PFT, and he is the best person to talk to us about this. Over to you, Dr. Atri.
Thank you for the very kind introduction. Dr. Devi Jyoti is a great friend and she moderating today is wonderful. Thank you, Dr. N.K. Singh, sir, for the opportunity. Yeah, so I am based at Ranchi, Jharkhand, and today we are going to talk about interpreting spirometry, which is commonly known as PFT, stands for Pulmonary Function Test. In clinical practice, the must-know pearls. I believe after the COVID pandemic, every physician must know about chest diseases, and we cannot know about chest diseases without knowing about PFT. Absolutely necessary. I want to thank Dr. N.K. Singh sir for the opportunity. Special mention of Dr. S.K. Mishra sir for Ranchi, who introduced me to this beautiful group CME India. Dr. Sandeep Salvi and CREST team who are based at Pune for teaching me the various nuances of spirometry, which maybe I will be presenting here also. Now, blood pressure. How can we measure blood pressure? We cannot measure blood pressure by looking at the face of the person. We need a machine to measure blood pressure. Sugar. Again, we need a machine. Creatinine or kidney function. We need a machine. ECG. Cardiac function. We need a machine. Bone mineral density, bone health, we need a machine. Presence or absence of pregnancy, beta HCG, we need to measure it. Brain related action, EEG, we need to measure it. Various organ specific imaging, how are the gallbladder, how are the kidneys, how are the eyes, we need to measure it. So we cannot measure any organ function. We cannot measure difference between health and disease without all these machines. So the moment we are talking about the lungs and especially about the lungs, something known as the airways, जिसको हिंदी में सांस नली भी बोलते हैं, we need PFT, pulmonary function test or spirometry. Very famous ghazal, जगजीत सिंह जी, सांसें देकर अपनी संगीत अमर कर दो. The patient has come to you with difficulty in breathing, deficiency in breathing. So how can you return the sanse to the patient without understanding spirometry? That is why every physician in India seeing chest cases needs to understand spirometry. After 1 p.m. or after 1 hour, all of you here will understand what is spirometry. Why do we need spirometry? Diagnosis, diagnosing diseases, ruling out or excluding diseases. Suppose a patient has come to you with patient who is afraid or anxious. Even then, unless you do a spirometry and show to the attendants that everything is normal, how can you rule out that? Prognosis. Whether a disease is good or bad. Follow-up. A patient has come to you on follow-up. How will you know patient is getting better or not? Convinced to take medicine. By a spirometry, you can prove to the person that this person is justified in taking inhalers and this person will get better by inhalers, because often in our country, people share to me they have some fear or social stigma regarding taking inhalers. Just like all of you here will agree that there is social stigma in taking insulin. कि सर इंसुलिन तो नहीं है, दीजिएगा तो लास्ट में लेंगे. So similarly, spirometry can convince the person that you need to take inhaler in getting better. Pre-surgical evaluation. Suppose you need to do a surgery and for anesthesia, how can you be sure that this patient would tolerate the anesthesia very well? And a very important thing, smoking cessation. Spirometry can be used in telling a person that yes, you will benefit by smoking cessation. And even after smoking cessation, a repeat spirometry can tell a person that yes, you are actually getting benefit by smoking cessation. In spirometry, there are two things. One is the values and one is the figure or graph. Please always interpret the graph and the values together. Never interpret the graph without the values. Never interpret the values without the graph. When we were in primary school, we had heard about Jack and Jill. ये सब ना famous जोड़ियां है. Then when we started looking television, we had heard about Laurel and Hardy. In Indian cricket, everyone has heard about Sachin and Saurav. Those who follow international football in Germany, they will tell Lothar Matthaus and Jürgen Klinsmann. In tennis, it's incomplete without Leander Paes and Mahesh Bhupti. And in music, it is incomplete without Shankar and Ehsan. Similarly, spirometry is also about that pair, graph and the values together. This is a graph This is commonly known as the flow volume loop. The y-axis here represents flow, that is volume of air per second. And the x-axis here represents the volume. So, look at the peak at the curve. For this spirometry to be legible or valid or interpretable, the peak must be reached inside 1 second or almost instantaneously. That peak is something known as PEF, or peak expiratory flow, or the maximum amount of breath someone can take out, that is known as PEF. From that peak of PEF, the slide starts. That slide is known as the exhalation part, and below the x-axis, the negative y is the inhalation part. So for this curve to be interpretable, the top should be reached at the earliest. If there is any hesitation in reaching the top, the values may falsely change and we may get some wrong values. So first thing, you must look at this curve, whether that peak is reached instantaneously or not. Second thing, whether a beautiful curve or a closed box is being formed or not. Sometimes this closed box is not formed, then also it may be wrong. Third, this entire exhalation process, here there is no time mentioned, but the entire exhalation process must be 6 seconds. Means person doing this test must be able to do it for 6 seconds. These are few things we must look before we tell that yes, this curve is right. Now let us look at the values. Let us try to interpret it. So what are the acceptability criteria? There should not be a cough during the test. There should not be any glottic closure during that forced expiratory maneuver. Early termination, you must reach 6 seconds. Submaximal effort, if someone has not exhaled hard enough. Leaks, the face or interface had come out from the mouth. So these are certain things during the test. And between the maneuvers, suppose you need multiple maneuvers, the two largest value of FBC must be within 0.15 liter of each other. Two largest value of FEV1 must be within 0.15 liter of each other. And if the value is less than 1 liter, then at least 100 ml of each other. These must be there for it to be counted that yes, I can interpret this test properly. Because suppose someone has not done the maneuver properly and you are interpreting it, then you can get something else. So this is how look at the top, how a normal spirometry trace or a normal spirometry flow should look like. Below there are some garbad. Like first, there is a cough in the first second. So the patient was unable to reach the top PEF. Second is variable effort. The person did not give the proper hardest effort at one go. Third, glottic closure. During blowing out, there was some glottic closure. So terminating the maneuver in less than 6 seconds. So if this kind of curve occurs, you can tell the patient that, boss, I need another attempt from you. This attempt is not going to be interpreted. When you look at the report, the various new companies are coming. That, oh, I have got the best machine in the world. I have something from Switzerland, and that beauty of Switzerland I am presenting in India. So in my spirometry, there are over 200 parameters. So do you actually need to read those 200 parameters? No. You need to read very few parameters. So when that company will come to you, because I want, and NK Singh sir also wanted, after this lecture, all you physicians should be able to acquire a spirometer from tomorrow. That is the exercise of this seminar today. So when you meet any sales company tomorrow, and if they talk to you about 20 readings, 25 readings in one report, they are of no use. They are just to confuse you. So what is needed by FEV1, forced expiratory volume at the first second. FVC, forced vital capacity or maximum amount of air you can blow out in 6 seconds or more. The ratio between these two, FET, forced expiratory time, again, it must touch 6 seconds. And if it goes beyond 6 seconds, let's say it touches 10 seconds or more, it is virtually diagnostic of a fixed airflow obstruction or COPD. PEFR, the peak expiratory flow rate. This is a wonderful prognostic maneuver. Like someone had a certain PEFR today, and after 3 months of your medicine, the PEFR has increased by 20 to 25%. So you can happily tell the patient that, look, you are getting better with Y medicines. You are getting better with maybe USV medicines. You never know. FEF, 25 to 75%, is something known as the mid-expiratory flow rate, which is a proxy marker or an indirect measurement of the small airway portion of our airways. So just these few readings you need to remember. Everything else is superfluous, luxury, design, competition. But these are few things you need to see in a spirometry report, and don't look at so many maneuvers. Don't be confused by so many readings. Spirometry is incomplete without something known as the prediction equation. This prediction equation depends upon height, weight, age, gender, race, smoking status. I would want to share a secret with all our panelists here. Our moderator, Dr. Devi Jyoti, when she was doing post-graduation at Delhi, she was doing under a certain professor known as Dr. S.K. Chabra. In Indian machine, this Dr. Chabra, he's a very good scientist, and he developed the spirometry equations for Indian machine. And whatever spirometry machine you use, it is actually a person who is living with us today, who is working with us today. It is not any foreigner whom we have never met. So, and Dr. Devi Jyoti had the good fortune of being taught directly by this gentleman. So, spirometry gives us total 3 types of pattern. It can be a normal pattern, it can be something known as an obstruction pattern, and it can suggest restriction. Now, since we are talking about the airways, so the biggest disease that can hit the airways is some blockage or obstruction in the airways. Just like when you're talking about cardiology, the most important disease you people treat is obstruction in the coronary blood vessels. Similarly, here we are talking about obstruction in our airways. It is the most common lung disease, and spirometry is the best test to measure obstruction of the airways. So these are just 3 patterns, and these 3 patterns can tell you so many things about the human body, not only just the lungs. What is the concept of obstruction? Suppose there is a balloon full of air, and you want to empty out that balloon. The balloon is tied to a straw. If the balloon is tied to a narrow straw, then the air will come out slowly, 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 slowly. If the balloon is tied to a large, wider straw, then the air will come out fast, 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 fast. So, our lungs is a balloon and the airway is the straw. If our airway is normal or large straw, we can empty our lungs faster. And if there is any obstruction in the airway, small straw, we can empty our lungs slower. As simple as that. This is the concept of obstruction. And this is how our curves start looking like. The green, like in the signal we see green, gaadi chalana hai, so green is normal. Red, khatra hai, ruk jaiye, red is obstruction. Suppose the normal curve is shaped like that. Means a person in 1 second will be able to empty more than 70% of the lungs, preferably more than 80% of the lung. In 1 second, person will able to empty out more than 80% of the lung in 1 second. So why? Straw is normal or large. And when there is starting obstruction inside it, that capacity will start coming down from 80. The moment it reaches below 70%, we use a medical term known as fixed airway obstruction. मतलब इनके सांस नली में अब एक परमानेंट रुकावट आ गई है, तो फिक्स्ड एयरवे ऑब्स्ट्रक्शन इज ऑल्सो नोन एज COPD or emphysema or various other parameters. So in obstructive airway disease, less than 80% of the capacity is emptied out in that first second of the forceful expiration. So that's why the red curve, look, it has reached the peak also later after 1 second, and it is not reaching the same level as the green curve. Why? Because of that blockage in the airway, the total lungs cannot be emptied like that of healthy person. And as this obstruction worsens, this red line comes lower and lower. The peak of the red line comes low, blunt or blunt. It becomes like that. Again, this is that flow volume loop or closed. Normal person will reach that top at the earliest. In obstruction, the top would be lesser than that because we are being unable to empty 80% of our volume inside the first second. So that peak is coming down. The normal curve, when it is descending, it is a very smooth descent. But when the obstruction curve, it is descending, you can find a concavity in it, a slide like or coving of the curve known as concavity in the obstruction. So this is how an obstruction curve looks like. So you need not memorize any value to tell whether the person is suffering from obstruction. You just need to look at the curve. If the curve hits the top portion much less than normal, less than 80%, and if there is this concavity, coved out portion in the descent, then you can say this person is suffering from obstruction. Again, look at the extreme right of the curve. The normal curve touches that origin at one point and smoothly goes below. But the obstruction curve towards the end, it becomes almost parallel to the x-axis. So these are three portions. Just by looking at the curve, you can tell that this person is suffering obstruction or absence of obstruction. As simple as that. Grading of obstruction. The spirometer is such a valuable tool that you can tell the patient that, see, you are suffering from obstruction. Patient will tell, is my obstruction mild or is my obstruction serious? You can tell regarding the grading of obstruction. In our country, there are two main types of obstruction. One is known as asthma, one is known as COPD. When you look at the predicted values for FEV1, if you find that anything is beyond 80%, you can call it mild. If it is between 60 to 80%, you can call it moderate. If it is beyond 60, below 60%, you can call it severe. For COPD, the demarcation is 80, 50, 30. FEV1 greater than 80%, you can call it mild. FEV1 50 to 80%, you can call it moderate or gold 2. 50 to 30%, severe, less than 30%, very severe. And how does the curve look like? The green is the normal. The yellow is somewhat less than that. So you can call it mild. But look at the red. It is much below the yellow, and that we can see that concavity, and towards the extreme right, how that red line is becoming parallel to that x-axis. So that is severe. What is that black broken line? A restriction curve looks something like that. A restriction curve shape is just like a normal curve, but it is a miniature version of normal curve. Like often in circus or in movie, there are that comedy star. The person looks an adult, but the height is that of a child. So think of that as the restriction curve. दिखता adult जैसा है, कद आधा है. That is restriction curve. Reversibility. Reversibility means हमारा obstruction ठीक हो सकता है या नहीं हो सकता है, and reversibility is the hallmark of asthma. Asthma is a disease where there is a dynamic or intermittent obstruction, and by giving some beautiful medicine, you can reverse the obstruction. So by proving reversibility to the patient, you can tell the patient कि आप ये दवा लीजिए, आप जरूर ठीक होइएगा. SABA is a class of medicine, short-acting beta agonist. Salbutamol, levosalbutamol, these are inhalers. After doing one test, give 200 to 400 microgram of this medicine, wait for 15 minutes, repeat the test, and after repeating the test, you will find 10% and 200 ml improvement in FEV1. This confirms something known as significant reversibility, and this proves the diagnosis of asthma. Again, in our country, often we find patients and their relatives have certain taboo regarding asthma. I get patients sometime who has, let's say, consulted one of our learned colleagues. I find our learned colleague has done the right treatment. Then I ask the patient, के साथ तो सही इलाज हुआ है, आप मेरे पास क्यों आया? देखिए ना डॉक्टर साहब बोल रहा है कि हमारा बेटी को अस्थमा है. कैसे हमारा बेटी को अस्थमा बोल देगा? हमारा बेटी क्लास में टॉपर है, हमारा बेटी को गाने में प्राइज मिलता है, कैसे अस्थमा बोल देगा? In these painful social situations, you need a spirometry to prove to the parents that yes, your child has asthma, but please don't worry, please don't take tension. Asthma has something known as reversibility. So if you take the medicine properly, your child is going to be perfectly okay. She can continue coming first in class. She can do wonderful academic career. She can do wonderful singing career also by taking this medicine. So spirometry is something which can help you convince the patient to take medicine to get better. There are three spatial curves which can be diagnostic in spirometry. These three spatial curves represent three unique kinds of pathology where you must immediately look towards those pathology only. Look at these three shapes. On my extreme left is something known as a fixed obstruction, intra or extrathoracic. What do you mean by fixed obstruction? There is some mechanical obstruction. It may be some permanent shortening of the airway caliber. Let's say someone had an airway injury from outside, something known as stenosis. Or it may be, let's say, a thyroid gland pressing on that airway. Or it may be an internal large airway growth, a glottic growth, supraglottic growth. Then the curve will look like that box. Moment you see that box-shaped curve, please refer to your ENT friend to do a laryngoscopy as early as possible, because this can be something deadly. Central airway obstruction can kill a patient inside minutes, and there is no medicine that can help in a central airway obstruction. So if you get something known as stridor, or if you get that first curve on the left, immediate refer to your ENT friend. Don't wait for your blood reports to come. Suppose you had sent for, let's say, a patient has come with fever. You had sent some urine culture, sputum culture. Don't wait for your report. The moment you get this spirometry, refer to your ENT friend. You can get something deadly. The curve in the middle is something known as a extrathoracic obstruction, variable or dynamic. This can be sometimes, let's say, a thyroid with a intrathoracic extension, and that is causing a dynamic compression. So extrathoracic obstruction variable. Again, you can examine the neck properly, that whether there is any some pathology in the neck or not. And the third curve over here, peculiar curve, intrathoracic obstruction variable. Suppose there is some foreign body inside, which is sometimes causing an obstruction, sometimes opening up due to a ball valve mechanism. Then we can get, so if you get these three spatial kinds of curve, these are beyond normal, immediately take help of ENT, think of deadly things if you get these three spatial curves. So this is the beauty of spirometry, that a spirometry can talk about prognosis. Whether a patient has got anything immediately bad or not, you can tell by this spirometry. Steps of interpretation. Look at that FEV1, look at that FVC. If FVC is above 80%, it can either be a normal curve or it can be an obstruction curve. Only if FVC is less than 80%, you need to think about restriction. Then look at that ratio of FEV1 by FVC. The moment you tell FEV1 by FVC ratio is less than 70%, you are looking at a fixed airflow obstruction or COPD. If the FEV1 by FVC ratio is greater than 70% and the FVC is less than 80%, this suggests restriction. If FEV1 by FVC greater than 70%, FVC greater than 80%, and you are not getting any reversibility, that can be a normal curve. For children empty their lungs so beautifully that for adults, if I mention 70%, for children, the demarcation is 85%. And if FEV1 by FVC less than 85%, that is virtually found in asthma, because COPD or a fixed airflow obstruction is very difficult to find in children unless it may be a case of congenital emphysema related problem. So you just need to treat this much only and you will get a diagnosis. But look at the curve, look at the graph first, then look at the predicted values. These are some model curves. The red curve is something pre-maneuver or before the medicine. After the red curve, we gave that inhaler, SABA inhaler, short-acting beta agonist, 200 to 400 microgram. We waited for 15 minutes, and after 15 minutes, we repeated the maneuver, and the blue curve is the post or after the medicine. We can all see the blue curve is reaching much, much higher values than that red curve. And if you look at that flow volume loop, the red curve has a beautiful convexity. At the bottom, the red curve is going parallel to the x-axis, whereas the blue curve in that slope, it is losing that convexity and it is not going parallel to the x-axis. So here there is an obstruction in the red curve. After medicine, this obstruction is getting better or there is a significant reversibility. So obstruction with a significant reversibility is something known as asthma. So this is how asthma case with significant reversibility looks like. So you can tell the person that yes, you are suffering asthma. But second, if you take your medicine, especially inhaler properly, we can get your asthma better. Maybe you can even reach a remission. So this is how asthma curve looks like. I am not even mentioning the values. After looking at these curve, you don't even need to see the values. The values are just for your confirmation. Why? Suppose patient asks you, sir, kitna percent lung? So then you can tell that the value, that see the value of FEV1 is this much percentage, value of FVC is this much percentage. But just looking at the curve, you can give a diagnosis. Next photo. Now, the blue and the red, there is hardly much change. Means even after the inhaler, the blue is little bit more than red change. And if you look at the curve, look how severe that convexity is. Like someone has sat on it. It has become like a sofa. It has become like a chair. Someone has sat on it and it is almost parallel to that x-axis. So this is how a severe obstruction looks like, and there is no reversibility. There is no change between the blue and red. So severe obstruction, no reversibility. This is how a severe COPD looks like. So this is how COPD looks like. Restrictive lung disease is like those bauna, dwarfs in cinema, or bauna or dwarf in the circus. Just looks like an adult, but the height is less than adult. So both FEV1, FVC values are low. FVC is definitely less than 80%. And FEV1 and FVC ratio is above 80%. So it looks like a mini normal graph. But one thing I want to give disclaimer, spirometry cannot prove restriction. Spirometry can suspect or suggest restriction. For restriction, ultimately, you need to do some advanced PFTs, which we can take future discussion also. So spirometry suspect restriction if you get these kind of curve. Restriction means that ability of that lung to expand, contract beautifully is lost. It may occur due to some weakness in the lung parenchyma. It may occur due to pleural pathology like pleural effusion. It may occur due to chest wall related pathology, kyphoscoliosis, neuromuscular weakness of the chest wall also. FET, forced expiratory time. A valid spirometry patient must exhale for 6 seconds, but for healthy people, 80% of the lung is emptied in 1 second. After that, if you blow, emptiness should comes out. But some people need 10 seconds or more to empty their lungs. Why? Because that airways are so narrow or that straw is so narrow. So this suggests COPD if that FET is greater than 10 seconds, that is diagnostic of COPD. Like suppose a married person is a smoker and married person is having lot of problem. So the spouse, either the husband or wife is very worried and brings us. And this person is like that, only if my spirometries come wrong, only then I will quit smoking. And if you get this FET of 10 seconds, you can tell confidently to the spouse that you should now start this person to quit smoking. This is COPD. So this is how these small parameters can tell us about prognosis also. FEF 25 to 75%, small airway disease index. What is small airway? Inside the lung, after the larger airway bifurcation, there is something known as bronchiole or smaller airway. Certain diseases start from this bronchiole, like connective tissue related lung disease. Then if there is some air pollution or chemical dust related lung disease, some metabolism related lung disease, they start from that small airways. So this FEF 25 to 75% is a marker of small airway disease index, but it is very less sensitive and the accuracy is doubtful. Means the reproducibility of this test is not there. In real life studies, what they have found, that the same patient on different machine was getting different values. Same patient on different maneuvers on the same day was getting different values. So some newer known tests like oscillometry is trying to replace it. So FEF 25 to 75% on spirometry is becoming less popular, less accurate nowadays. PEFR, more for prognosis. Like today, someone's PEFR was 2 point something. After medicine, that person PEFR became 5 point something. So you can tell that you can blow better now. So your lungs capacity or that obstruction is definitely getting better. So PEFR is more for prognosis. Like follow up, you can tell that, see, from previous, your PEFR is getting better. Or sometimes we get very intelligent patients who are more intelligent than us. They don't take the medicine. Then they will come and you can show that, see, your PEFR is come down. That means you're not taking the medicine. So this is how PEFR helps in the follow-up. Pre-surgical evaluation. Generally, a person with a FEV1 greater than 1 liter can tolerate beautiful surgeries with wonderful anesthesia. So, spirometry, FEV1 greater than 1 liter, you can tell the patient or you can tell the surgeon or anesthetist that you can go forward with your surgery. There will be no problem in extubating the patient. There will be no problem during recovery of the patient. And for pre-surgical evaluation, it is very essential to identify and treat asthma because lot of anesthesia, painkillers, analgesics have got trigger for asthma. So that is why also this is pre-surgical evaluation, spirometry is an essential tool. That wherever you have a difficult surgical candidate, please do a spirometry first. Smoking cessation. FEV1 and FVC both worsen due to smoking, and after quitting smoking, both can get better. So this can serve as a warning for someone to quit. And after quitting, let's say after 3 months, you can do a repeat to tell that whether you are getting better or not. If I want to summarize, I cannot diagnose obstructive airway disease of lungs without spirometry, and obstructive airway disease is the most common disease of the lung. Maybe 80% of chronic lung disease in our country is obstructive airway disease. So, such important lung disease cannot be diagnosed without spirometry. Please look at the graph, learn to read the graph, and then add the values. FEV1, FVC, and the ratio are the most important parameters. Baki are all mohmaya. Like roti kapda makan is FEV1, FVC ratio. Baki are deluxe thing, Apple Watch or luxury car, or let's say lift in the building. Baki are deluxe things. But FEV1, FVC ratio are most important. Roti kapda makan. Spirometry not only gives me diagnosis, it can tell severity of the disease, mild, moderate, severe. एंड इट कैन टेल प्रोग्नोसिस, आपका रिवर्सिबल है कि नहीं, समय के साथ आपका बीमारी इंप्रूव किया कि नहीं, डाउन हुआ कि नहीं. सो दिस इज हाउ I would want to summarize, as simple as that. And now I am sure madam will ask question from herself also, and I may be wrong at some places because madam is a professor, she teaches children, I am more of a practitioner, so I may be wrong somewhere, so that also madam will correct definitely. This is my phone number. Anyone who needs, let's say, some help in, like from tomorrow you are purchasing spirometer, if you need help in understanding, you can take my phone number. I may not pick up the phone, but on WhatsApp I religiously reply every 10 to 15 minutes. So over to ma'am now.
Thank you so much,
Yeah,
Dr.
excellent. Yeah, excellent one. So, madam, so please stop sharing first.
Dr.
Yeah,
Atri.
madam.
Yeah. Thank you, Dr. Atri, for this beautifully explained explanation about spirometry. I'm sure every physician, every doctor who has joined today is taking home the pulse as we had intended to do. I want to emphasize on certain things. Obviously, Dr. Atri has touched upon it, but I want to emphasize a few points. Never do a spirometry when the patient comes to you in exacerbation. If अगर patient आ रहा है, उसकी सांस बहुत जोर से फूल रही है, you need to hospitalize him. Hospitalize, start the supporting treatment. During the discharge, you can do the spirometry and see the severity and give the treatment on discharge. Second, asthma is a clinical diagnosis. You don't need a spirometric obstruction always for asthma, especially because asthma is a maybe an episodic disease, like during rainy season or during winters, the person is having symptoms. In between, his or her lung function is absolutely normal. So if he or she comes to you in between and the lung function is normal, it doesn't mean he or she doesn't have asthma. May have asthma, but she is stable now. So as Dr. Atri has beautifully mentioned, that it also tells you about the prognosis, like as he or she has taken inhalers, now the values have come out to be normal. Third thing about the reversibility. For the reversibility, both volume and percentage should be there. 200 ml change and 12% change, both of the value should be there. If either of them is there, we will not say that the spirometry is or the volume is reversible. However, reversibility does not differentiate between asthma and COPD. Many a times we see COPD patients with reversible spirometry. There was a term echo asthma COPD overlap. It has been arbitrated now, but reversibility is not a essential criteria for asthma. And as Dr. Atri has just shown us a beautiful graph of central airway obstruction, fixed obstruction, which is a box kind of loop. So if you find that, send the patient immediately to a surgeon. However, in a few cases of central airway obstruction, we may get a normal spirometry, or we may not find that box. So if you are suspecting a stridor or central airway obstruction, do not wait for that box to appear. And before that also, you should send. Those are my inputs. And as we all know, Dr. Atri is the pioneer of oscillometry in Jharkhand. Spirometry is indicated only in children above 6 years. So below 6 years, you cannot perform spirometry. So in those cases and in sick patient or elderly patients, oscillometry is proving to be of better beneficial role in diagnosing diseases. Now I think if
Getting some
and
question
Ma'am,
all-
in the chat
there are
box.
few questions. Please take that question from the chat
Yeah.
box.
Yeah.
so
Question 1.
yeah.
65-year male, interstitial lung disease, referred for a lung transplant workup. The person is on oxygen 4 liters nasal cannula with SpO2 only 90%. BP 100 by 80, tachypnea 30 breaths per minute, heart rate 90, afebrile. Which spirometry parameter can be of a help? When we are talking about interstitial lung disease, this is not an obstruction, this is a restriction. The most important spirometry parameter in restriction is something known as FVC, forced vital capacity, and in interstitial lung disease, various drug trials have committed that FVC also has a prognostic value, that if with time FVC is falling, the patient is at risk for dying. But here FEV1 is also important, because FEV1 very low, person may be at immediate risk of dying. Means if FEV1 is coming less than 50% or in the severe category, so that person would need immediate treatment. But again, like madam told, the spirometry is something for a stable patient. So if this person is on 4 liter oxygen, respiration 30 breaths per minute, this person may not be able to perform the spirometry properly. So spirometry FVC will help in this patient, but this person may not perform also spirometry properly. Second question, they are asking measurement of static lung volume, including FRC, for making definitive diagnosis. FRC or lung volume is more important in restricted lung diseases, or where there are certain structural abnormality in the lung. These cannot be measured by spirometry. There are two tools to measure this. One is known as a diffusion capacity plus lung volume, and another thing is known as body box or body plethysmography, which can measure these. Spirometry will enable it to measure these things. Third question, 2019 ATS or ERS, they are talking about race-specific equations should be used. What is your take? Yes, race matters in spirometry, but again, if you look at it from common sense, the world has become a very small space. Like Dr. N.K. Singh over here, he is in Dhanbad on Monday. Tuesday, he has gone to another continent. And by Thursday, again, he is back to Dhanbad. Dr. Devi Jyoti, when she was doing post-graduation, her research was selected for some European prize. But her professor told that I will not give you leave more than 4 days. So in 4 days, she had to go from Delhi to Europe back to Delhi. So when the world has become so close space now, there is a lot of racial intermingling. Means suppose there is a patient with parent of one race and another parent of another race. There what will you do? So that can happen. You cannot tell someone that no, my spirometry does not support race specific equation. So your parents should not be of different races. Tell them to be of the same race. We cannot tell like that to some patient. So race specific equations will slowly go out of favor with intermingling of people. My two classmates, they are Indian and their spouses are not, one is of Asian origin and one is of European origin. So when their children will come, what race will you put in that spirometry? Very difficult. So that's why race specific equation should go out: age, height, weight, smoking status, gender. Fourth, detecting early disease in the small airways. What is your best recommended approach? Number one, don't think of test. Take the history. Anything disproportionate means the patient is breathless, patient is having symptom, but on examination, you are not getting any finding. Then you think of the small airways, because the small airways are so small that you will not get any positive finding on auscultation, percussion, palpation, inspection. But the patient has having disproportionate symptom, examination normal, think of small airways. Something known as oscillometry can help you. Something known as a beautiful HRCT scan with inspiratory and expiratory curve cuts can help you. Spirometry may not be able to help you. These are few questions I got from the admin. And now comments to our other respected senior members, please.
Dr. Atri, I have got two questions. One is, what is the open loop and what is the closed loop spirometry? Anything like open loop and closed loop?
These were historical terms when we were talking about the quality of the spirometer. But now, as we have better flow, like previous spirometer, what happened? They were volume displacement spirometer. The spirometer was a cylinder. When you were blowing air, you were actually replacing the air in those cylinder. Then this terminology were used. Dr. Devi can answer this better because when she did from Patel chest, they had all those historical spirometers to see actually. So maybe Dr. Devi will answer this more.
Rightly explained by you. Earlier, we used to have that pneumatograph for this assessment. At that time, we had open loop or closed loop. All the newer machines we are having now has a flow volume and a volume time curve. So those two curves only we need currently.
Dr. Atri, there I just went through the literature. I got one literature where in the diabetes, role of spirometry in diabetic patients. Some authors are now recommending that it should be a comprehensive management part of all diabetic patients. What's your both yours track, madam, and Dr. Atri yours?
The
Should
most
it be a
important thing,
comprehensive? Yeah.
the most important thing we are scared in diabetes is this end organ glycemic complication, microangiopathy. Like microangiopathy occurs in other organ, microangiopathy will also occur in the lungs. So uncontrolled diabetes can also lead to small airway disease, and if small airway disease develops in the lung, it becomes very nasty to treat. So person with uncontrolled diabetes or person with long history of diabetes, and let's say your beautiful cardiac evaluation is normal, and if you get something in the spirometry, a restrictive pattern, you're getting something like a small airway pattern, then that can be due to that end organ complication. Secondly, lots of new diabetes related medicine is coming, or sometimes person can develop allergy from newer insulin analogs also, or a person can get, let's say, bronchospasm from these newer insulin analogs. So after treatment of diabetes, if the patient or the family is talking about cough, irritating cough, then also you can do a spirometry plus reversibility to understand whether person is developing some new onset allergy or asthma from some diabetes medicine or not. However, this has been reported, but it is not common. Maximum insulin patients in India do not get this. This may occur in other continents like India. We are so close to nature. From childhood, a child is exposed to so much of nature that these things very rare in India. When maybe European or that ultra developed nation, these kind of thing can occur. Madam's opinion also on this.
Yeah. One important thing, COPD is not only a lung disease. COPD is a systemic disease. So whenever we have a patient of COPD, we should always assess him or her for diabetes, osteoporosis, depression, bone diseases, many things. So as you have rightly said that many a times we have diabetic patients with concomitant abnormality in spirometry, and nowadays as microangiopathy and everything is taken into consideration, abnormal spirometry is commonly found in diabetics. Second point, a diabetic when comes to a physician with breathlessness, the first thing that comes to our mind is coronary artery disease. We do an angiogram, it's normal. He or she may have COPD or abnormal lung function. So it's always better to have a lung function when you diagnose a patient of diabetes, especially because it may tell you about involvement of the small airways because of the microangiopathy, or he or she may or may not have a concomitant COPD or some abnormal lung disease. So it's always better.
Dr. Atri, is there any complications while doing the spirometry?
Very important.
I wanted to ask, what are the absolute and relative contraindications to doing spirometry?
Beautiful. Sick patient or someone in an acute respiratory distress, please don't do a spirometry. We need to wait at least 4 weeks for an acute respiratory problem to settle down before doing spirometry. Open MI, acute coronary syndrome, inside that unstable period, don't think of doing a spirometry. Intracranial tension, raised intracranial tension, don't think of doing a spirometry. person should do spirometry always sitting, never standing, because sometime during that forced maneuver in standing person, there can be a syncope leading to injury also. So absolute contraindication would be acute respiratory distress, open coronary incident, and Baki madam will also contribute.
Yes. Acute MI within 1 week, preferably within 1 month, we should avoid. Recent surgery, abdominal surgery, hernia surgery, some sort of things within 1 month. Recent eye surgery, cataract operation within 1 month, you should avoid. Active hemoptysis, you should always avoid. If you think patient is infected, if possible, avoid. If you can treat without doing a spirometry, please do treat. If it is essential, keep that patient at the last in the day.
There are
So,
many female patients who are coming in who have stress, incontinence, and so
yes,
who say that on coughing they pass urine and all.
yes.
So, any particular precautions to be done in such?
No,
Not at all.
for such patient, they will have incontinence while doing the spirometry, but there is no specific recommendation or precaution for that.
Which are the patients to be referred for advanced spirometry?
When the spirometer is suspecting restriction, then the better evaluation cannot be possible with spirometer. So when you are thinking of interstitial lung disease, when you are thinking of connective tissue disease related lung disease, you need to think of advanced spirometry. The moment you are thinking of small airway disease, think of advanced spirometry. If you are thinking of pleural disease, please don't do spirometry. In pleural disease, your ultrasound will help you more.
So I think that question was very important about the complications while doing the spirometry. Like, can patient develop the respiratory alkalosis also while doing the spirometry?
Uh,
Uh, Hyperventilation does not occur because in the maneuver, you're taking that deep breath, you're doing a forceful exhalation. Only when there is hyperventilation, then such a thing will occur. So from spirometry maneuver, a respiratory alkalosis should not occur.
Yeah.
also,
So I think this is a wonderful session today. Now I will request Dr. Vijay Patni to talk about significance of this session and to conclude the session. Dr. Vijay Patni.
Thank you, Dr. N.K. Singh, for taking this particular session. Actually, it was extremely important tutorial class, and Dr. Atri has done it lucidly. And Dr. Devi had definitely added lots of practical points to this particular spirometric class, I would say. And one thing was very important. I think both of you have figured out in any patient with diabetes, the first suspicion when a SOB comes is cardiac case, right? And then what we'll end up with is a coronary angiography, which is found to be negative, correct? So these cases, ideally, should be the other way around. A spirometry should be done. I mean, I do say day in and day out, such patient, and they'll end up with a spirometry later, and we can diagnose the case, as Dr. Atri has very well explained. And this is not very uncommon as well. So this is one point I would like to stress upon, that one need to look into the clinical parameters before actually sending the patient for angiography, and then plan out maybe an easy tool of spirometry to diagnose the case. That's one point I would try to stress upon, and most of the other practical points have already taken care of, so nothing much to add about. And great work done by Dr. Atri and well supported by Dr. Devi. Thank you.
So lastly, Dr. Akash Singh, please give your comments and finally the vote of thanks.
This was a very important session, and spirometry actually is something which is as essential as an ECG or an echo, and all physicians, I think, should have a spirometer. It is a very durable machine also, and a very easy thing to do. And patients a lot of patients are not convinced that they are having allergic bronchitis or asthma or COPD, and it needs to be documented. That is my personal experience, and the same has been delivered by Dr. Atri, who has delivered his lecture so well. These are my basic comments, and I think the session was very, very clinically oriented and presented very lucidly. And I think that all the audience had a great time listening to him.
Yeah, so I think some vote of thanks for all, but I think really that Atri, you have done a great service to us. कई बार तो हम लोग को obstruction और restriction समझ में नहीं आता है ग्राफ देखकर. Today I have become aware कि how to interpret this as spirometry. So finally, vote of thanks, Dr. Akash, and then later
I
on,
thank,
lastly,
I-
Dr. Snehal and
I thank Dr. Atri for his excellent presentation of the topic and excellent making us understand in a very simple way the entire concept of spirometry and the basic pearls of spirometry, doing spirometry. I thank Dr. Devi Jyoti for her additional remarks and moderating the session and her useful insight into the topic. I thank Dr. N.K. Singh, who is a pioneer in continuing medical education across India, and Dr. Vijay Patni, who is an eminent academician, and his presence always boosts our morale, and we are always more enthusiastic for conducting such CMEs all along. I thank the entire USV team, especially Dr. Snehal Bansode, who is always with us for hosting these CMEs and for promoting the medical education across India and for providing the logistic support for such meetings. Last of all, I thank all the doctors who have attended this session because their attendance is the key to our enthusiasm and success. Thank you very much. I hand over the mic to Dr. Snehal Bansoda.
Thank you so much, sir. I must say, sir, we have been conducting a series of programs in CME India today, but today's session was an interesting one. If we had a term to break down complex terms into simpler understanding ways, that would have just been Dr. Atri, sir. He has fantastically elaborated on each and every aspect of spirometry today, and I'm definitely sure all the audiences who've attended this program have appreciated the topic as well as the fantastic oration by Dr. Atri, sir. Thank you so much, sir, for giving us your time. Again, here would like to thank Dr. Devi ma'am for the fantastic points which she emphasized on, which definitely on a practical basis will be of an help to everyone listening to us today. And last but not the least, Dr. Patni sir and Akash sir for your continued support for organizing these programs. And Dr. N.K. Singh sir, who is the blueprint behind CME India, who helps us put together such fantastic programs and helps us maintain this kind of enthusiasm throughout. So thank you once again to all the doctors for helping us make this yet another successful one. And we look forward to meeting you soon in the near future with more such interesting topics. Thanks once again from the entire USV team to all of you.
Thank
yeah,
you.
good night to you all. Thank
Thank you.
you very much. Thank you.
Good night.